So welcome everyone. Why don't we'll have our seats. We have so much information to get today, so very exciting folks to get to. I'm going to apologize in advance because I'm going to be brutal about time today, about keeping folks on schedule as best as we can. I want to say thank you to everyone for coming. My name is Jim Cantwell. I have the honor of representing Marshfield and Scituate in the state legislature. And before we begin, by the way, I want to make sure to alert everyone, this public meeting is being videotaped. For public record. Any testimony offered is also of public record. To begin, I want to introduce my partner at the State House, Tom Stanley, who's been for 20 years, has been a leader in state and local government. He's been a partner here in prevention, helped get this commission started with me with the legislation. Tom Stanley represents Waltham. Tom, please come right up.
Thanks, Jim. I just wanted to welcome everyone here to Waltham. You know, we're very honored to have such a prestigious commission doing its work here in our great city. And, you know, on a personal level, you know, as a state rep, we deal with behavioral issues all the time, with helping constituents and advocacy groups to help people. That's where we get, you know, some of the greatest satisfaction of our job. And also, you know, myself, I've lived with depression, and also I'm a recovering alcoholic, so I know the importance of the work that all of you do, and I'm looking forward to getting all the recommendations and doing whatever we can do in the legislative role once all the work is completed. And I know there's so much to do, and I just thank you. Jim tells me all the time how smart everyone is on this commission and comes before the commission, and I think he thinks he's a lot smarter now, and I bet he is.
Thank you. Thank you so much, Tom. So, thank you for everyone for coming. This is our 10th convening of our Promote Prevent Commission. I want to thank so very much the Education Development Center for hosting this very special public hearing. It's my pleasure at this moment to introduce Jim Vetter, who is the Associate Director of Health and Technology for EDC, who will be doing our presentations for some of our EDC members, including our president. Jim. And as Jim's coming up, by the way, Jim has been one of those brilliant people. It's been a pleasure to work with you, Jim, and to learn from you. We're so thrilled to have you as one of our commission members. Thanks for having us here. Thank you.
So thank you so much, Jim. We really appreciate Representative Cantwell's vision in championing this commission. And I feel very honored to be one of the commissioners on it. As Associate Director of Health and Technology here at EDC, the vision of this commission is so closely aligned with things that we care about here at EDC, about bringing people together, about starting early, about being able to really make the kind of change in communities that we need to produce the health of the community that we'd like to see. And I'd like to introduce our president, Dave Offensund.
Thanks very much, Jim, for giving me a hand with the welcome. As you can see, I need a hand. It's not casual Friday today. I just determined this morning that you cannot tie a tie with just one hand. That's just not possible. But welcome, everyone. EDC is just thrilled to be hosting this event. It's very, very important what we do. You may not know the breadth of everything that EDC does. We've been in business for about 60 years. And we have a wide array of programs in education, health, and international development. And at any one point in time, in fact, we're managing about 275 separate programs across all 50 states and in about 20 developing countries around the world. But we are all in on this subject because a big part of what we do, particularly domestically, is in the area of mental health, behavioral health, substance misuse prevention, and so forth. And just to give you an idea of maybe some of the things you know that we do and some of the things you don't know we do, in addition to providing support for the MASTAP program with, as a number of our team is in the room, which is providing technical assistance throughout the Commonwealth. We also manage for SAMHSA, the Center for the Application of Prevention Technologies, which is the national technical assistance organization that supports not just MASTAP, but similar programs in the other 49 states as well. So we are really committed to this. We also have some other sort of behavioral health programs. Certainly we, again, for SAMHSA, run the National Suicide Prevention Resource Center. We have a whole array of things we do in the suicide prevention area and in the injury prevention area. So it's really, really important for us. We're here because we care passionately about seeing improvements here, and we care passionately about helping to convey the word about what works based on evidence. So I think hearings like this really help to convey that information broadly. And so Representative Cantwell, thank you for your leadership on this, and welcome all of you. We're looking forward to a very exciting day. And so with that, I'll leave you and turn it back over to Representative Cantwell. Thank you.
Thanks, David. David, thank you so very much. And we, by the way, as a legislator, I'll note to folks that we have other commissioners coming in. Legislators are on legislative time, which means that I'll do introductory remarks for another 10 minutes, and then they will be coming in with us. All the commissioners who are here, 10 of them, we're going to do our lightning round of introductions just in a moment. First, but for EDC, Dave, thank you so very much for having us here. This is just what you do every day to bring knowledge to us. And Ben stepped out because I want to mention him in a minute. But for the folks here from EDC who put this together, thank you to Jim Vetter, to Lauren Gilman, Jeff Tam, Allison Cohen, and all the other wonderful staff that you have at EDC that put this together. It really is very impressive. I want to give an overview. Some of the commission members, this will be familiar to them, but to those who don't know, the impetus to begin this special commission began with one of your former staffers, Ben Thomas, who runs my office. Ben, some now 3.5 years ago, sadly, his aunt was one of those 1,400 folks who had overdosed and had died that particular year. And Ben, as a leader of his family, was in the hospital when the doctor came in to talk to his grandmother and to him to say that his aunt had passed away. And just a few feet away, outside that room, were another generation. It was his 3 nieces, nephews, who now no longer had a mom. And for him, he came to work the next day and said, this is something that is reverberating through generations. We need to do something about it. And what we did about it was really him working in concert with many others here around the room to help write this legislation to create the Special Commission on Behavioral Health Promotion and Upstream Prevention. Our special commission, we call the Promote Prevent Commission. For those of you who are new to here, we are tasked with investigating evidence-based practices, programs, and systems to prevent behavioral health disorders and to promote behavioral health access across the Commonwealth. One of the things that I say all the time, and I was saying to Michael Botticelli earlier, we know we're spending 97% of all the money that we spend right now, picking one issue on behavioral health, for substance misuse. You all know this in the room, 97% of what we spend is downstream. It's on things like Narcan, when we have a wonderful person from police or fire showing up to bring a person back to life. It's the cost for police or fire. It's people that were in the hospitals bringing people back to life. It's recovery coaches, great programs. We're pleased that we fund those. It's long-term treatment and recovery. Heaven forbid, sometimes it's folks who are being sent to jail. 97% of those funds downstream. This commission's been doing a phenomenal job bringing attention to what we need to do upstream for all sorts of behavioral health conditions. The commissioners know that we have 3 overarching questions of what we have been tackling. 1, what's working in behavioral health promotion and upstream prevention? Secondly, how can we better fund what is working, what's evidence-based? And the third, what can we achieve if we do this proper funding down for the long term? Our first meeting was to talk about the state of behavioral health. We had, from the Commonwealth, the Secretary for Health and Human Services, Mary Lou Sutters, came to testify. At the national level, Senator Ed Markey came to talk about what was happening nationally. Commissioners McCullough of the Department of Mental Health and Commissioner Burrell of the Department of Public Health and our Chief Justice, Paula Carey, all testified at that first session. Our second meeting was focused on the promise of prevention, where we featured leading minds throughout the nation talking of what evidence-based programs that they have done. We're going to hear from some today who are doing wonderful things, like Joe Strand here talking of Drug Story Theater here in Massachusetts. But we had leading minds from the Institute of Medicine, the Paxis Institute, and the Pew Charitable Trust Results First Initiative. I'm thrilled to have them back here today to give us an update from Pew Charitable Trust. In Results First, it is. June meeting focused on how we're going to pay for all of these prevention and promotion programs, work that we're still doing. In July, we had our first public meeting in Boston. This fall, we had meetings on mental health and violence prevention and a public hearing at Beth Israel Deaconess in Plymouth hearing of how they do an integrated care model, which we want to see and support around this state. For people who are watching or hearing this for the first time, you can get all of the notes, all of the videos of each of those meetings are online at promoteprevent.com, as well as to look for upcoming meetings as they are scheduled. For our hearing basics, please make sure for those who are here to testify, please sign up outside the door if you haven't done so already. We're going to take testifiers in the order that they've signed up, either at door or by email. Other than what we do, which is different from federal hearings, is we have invited guests who will have unlimited time as they do their presentations. But then thereafter, we'll take a very short break. For the public, folks, I hope you bring your testimony in hand. We do need to limit testimony to 3 minutes for public testimony, as we have about 30 people who would like to testify. We want to make sure everyone gets a chance to be heard. I want to make sure people know we are not focused on the treatment or recovery systems. They are very important, but as I stated at the beginning, that's where 97% of the funds are going right now. Our job is to focus attention on that 3% where we can do funding upstream. I encourage everyone who is either watching on the video, so it would be after this hearing, or those who are in the audience, please submit written testimony of your comments or your thoughts to testimony@prevent.com. Or, by the way, while you're here, feel free to tweet about the hearing or testimony tag at #PromotePrevent. So, before now getting started with our wonderful testimony, again, thank you for everyone for coming. I want to do a round robin for our commissioners who are here so that you know, Michael, before you come and testify, Catherine, before you come and testify, everyone want to know who we have before you. So we are going to start, Jim, we're going to start with you. We'll do a round robin coming right around here. Everyone to introduce yourselves. We are a sharing group. We're a close group. We have one microphone for every 3 people. So if you just share the microphone as we go. Jim, we'll start with you.
I'm Jim Vetter. I'm Associate Director of Health and Technology for the Education Development Center. And I'm also the Executive Director of the Social Emotional Learning Alliance for Massachusetts.
I'm Ann Gilligan from the Department of Elementary and Secondary Education, and I'm here filling in for Rochelle Engler-Bennett today.
Good morning. I'm Margaret Hanna. I'm from William James College. I'm the Executive Director of the Friedman Center for Child and Family Development.
Christy Hager from Beacon Health Options, Senior Vice President for Public Policy for the Northeast, and I sit on the commission as one of Governor Baker's appointees.
And I always keep saying Christy helped write the legislation that created our universal health care in Massachusetts. So
Only
keep
the good parts.
Our special commissioner, you're a special commissioner today.
Oh, you're already introduced.
Representative Tom Stanley, please.
Rosemary Minahan, Massachusetts Trial Court.
Steve Sidlovich, Legislative Director for the Department of Mental Health.
My name is Yamanet Diaz-Linhart. I'm a public health social worker, and I represent the Massachusetts chapter of the National Association of Social Workers.
Mary Ann Frangulis, Moore, Massachusetts Organization for Addiction Recovery.
I'm Phil Castle. I'm the Director at Mental Health Legal Advisors Committee.
So to start, for testimony now, Ben, if you want to come up, Ben Fulton, who's with the results first. As I mentioned in my opening comments, we have been so excited, and this whole commission is very exciting for the work that's being done. Ben represents Results First. That's a combination of Pew Charitable Trust and the MacArthur Foundation. They've been doing phenomenal work helping us as we're developing our report, developing our focus for our work. Ben, it was thrilling to talk to you yesterday, and welcome back. Look forward to your testimony.
Thank you. Hello and good morning, everyone. As Representative Cantwell said, my name is Ben Fulton. I'm a senior associate with the Pew MacArthur Results First Initiative. And I want to start this morning by just saying thank you for the opportunity to speak before this commission today and to give you a quick overview and update about the Results First work with this commission. I also want to say thank you to EDC for hosting today. And allowing Results First to take part in this really important day. So the Pew MacArthur Results First Initiative, super long name, but we go by Results First for short. It's a jointly funded effort by the Pew Charitable Trust and the John D. and Catherine T. MacArthur Foundation. And what we do is provide technical assistance to select states and counties across the country to help them build capacity and expertise in evidence-based policymaking, which for us means using the best research and evidence out there about what works to identify and invest in programs that have been proven to work through rigorous research and in cases where there's really strong research, produce a strong return on investment. So we do this work in a growing number of policy areas, including adult and juvenile justice, child welfare, mental health, substance use disorder, public health, and workforce development. So we help these jurisdictions engage in evidence-based policymaking processes by providing tools, training, and technical assistance as they go through a three-step process. First, we help them build an inventory of programs, which goes just beyond a list of programs, but also adding information about how those programs operate, the participants in those programs, the budgets for those programs, and ultimately comparing those programs to the research literature out there about what works that comes from a number of different nationally recognized clearinghouses. Then we help our partners customize a state-specific benefit cost analysis tool. And what this does is allow them to project the potential return on investment for a number of programs that have been rigorously evaluated, and there's a strong demonstration of their impact. And then finally, we help these jurisdictions put this information into action, looking for opportunities to, again, identify and invest in these strategies. And that's really the last kind of part of our technical assistance. So Results First is partnered with 27 states and 10 counties, including the Commonwealth of Massachusetts. We originally partnered with the Executive Office of Public Safety and Security, as well as the Office of the Trial Courts, as well as a number of different criminal justice partners to work in that policy area back in 2013. And we continue to work and expand that effort within those agencies, and building on that success with these criminal justice partners. We partnered with two additional state agencies, the Department of Public Health, Mental Health, through the Special Commission here today. And so we did that back in the spring, and since then I've been working with those two agencies to go through that three-step evidence-based policy making approach that I mentioned. So these agencies are going through a very labor-intensive effort and making tremendous progress. And so they are developing program inventories and customizing the benefit cost analysis tool to analyze a number of substance use disorder and mental health prevention and early intervention strategies targeted at school-aged children. And their work will highlight a number of potential programming investment strategies, and for some programs, allow the Commission to consider the potential return on investment of those particular funding strategies. And so this group, as I mentioned, is making its way through this process and doing a really incredible job. They've been really enthusiastic partners, and we're really proud of all their work and really happy to continue our work with them. And they're looking forward to presenting their information to the Commission and a number of different work groups that are part of the Commission in early 2018. So thanks for the opportunity to speak here today and work with all of you as you take on these really serious and important challenges and look for ways to make impacts in the lives of Massachusetts residents and their communities. So I will be hanging around afterwards if there are any questions, but to keep things on schedule, I want to make sure turn things back over to Representative Cantwell and just say thank you everyone for being here today and having the opportunity to speak.
Our next testifier is Catherine Power, who is the Regional Administrator, Region 1 for the Substance Abuse and Mental Health Services Administration, SAMHSA, an operating division of the United States Department of Health and Human Services. In that role, she represents the administrator at the regional level, fulfilling the agency's mission of reducing the impact of mental illness and substance abuse on America's communities. Mrs. Power is also a retired captain in the United States Naval Reserve. Catherine, thank you so very much for coming today. We appreciate your time and your expertise, and are thrilled to hear your testimony.
Thank you very much, Representative Cantwell. I really appreciate being included in this remarkable effort. I know I've tried to get to some of the other meetings, and you were graciously accommodating that I couldn't come until today, so thank you very much.
No, thank you.
I appreciate that. I also want to say thank you to EDC. EDC is a long and strong partner with SAMHSA, and they do remarkable work in the education field and in the health field, and we appreciate the fact that they're hosting everyone today. Let me start off with the fact that my background is that I was commissioner in Rhode Island for 10 years for mental health and substance use disorders. then moved to SAMHSA as the director of the Center for Mental Health Services and have been at SAMHSA for 14 years. What has happened in the last 6 years is that when the Affordable Care Act became law, Secretary Sebelius at HHS said, we want SAMHSA in the regions. We were never in the regions before. And so 6 years ago, we were designated as regional administrators. I am a one-person office based in Boston and responsible for the 6 New England states. So all of you here are my customers. You are all my customers in the sense that I represent a federal agency and I am the link to that federal agency for you in New England. SAMHSA, the Substance Abuse and Mental Health Services Administration, is one of the smallest agencies in the federal government, 600 people, $3.7 billion budget. Most of that money goes in block grants or in formula grants to the states, to grantees, and to tribes. We are called a demonstration grant program agency, and that means we demonstrate. We don't get money in perpetuity. We demonstrate what might be effective. So Congress directs us and tells us, take this pot of money, go find out what is working, what's a best practice, what's an emerging practice, show us it's an evidence-based practice, and then report on that. And in some cases, we are given continuous money to produce toolkits and to do other sorts of things. In other cases, we don't. And the demonstration grant ends after 3 to 5 years. And what do we learn? Well, we learn some things from the grant. But today, I really want to tell you that we are not the source of the most important information about prevention. You are. We simply, at the federal level, reflect what you do at the local and state level and try to bring those practices up to a level where they can be exponentially distributed. But you are the ones at the local and state level that teach us what are the most effective practices, and I really want to reinforce that notion. SAMHSA acts on the belief that all Americans should believe these 4 principles: that behavioral health is essential to health, that prevention works, that treatment is effective, and that people recover. We're not there yet. Not all of America believes all of these principles yet, but we're moving in the right direction. We had in 2016, throughout the year, what I call the trifecta, 3 major developments that occurred during the year of 2016 that laid the table for us in 2017 and 2018. The first was the Surgeon General's report on addiction, facing drugs and health in America, and all of these should be mined for possible prevention messaging. The second one was the Comprehensive Addiction and Recovery Act, CARA, which was a policy document that was significant in terms of looking at substance abuse and mental illness policy, and was in fact a very significant piece of legislation, but it had no appropriations attached to it. And then we came in December of 2016 to get the 21st Century Cures Act. That coupled the CARA policy with appropriations and with authority. And with that, we created a vast new domain in which we are now currently operating. And that vast new domain is unclear at this point about what the emphasis will be across prevention and promotion, across treatment and recovery, and across all of the other programs that have been going on at SAMHSA. We're about 120 days into our new leader. The 21st Century Cures Act gave us an assistant secretary for mental health and substance use. We have never had an assistant secretary before. It's always been an administrator. What does that do for us? What that does for us is that gives us a different level of influence, a different level of strategic influence, a different level of convening authority, a different level of exchange, a different level of advice and consent across the federal government and into other sectors. We think that that's an important step on the part of Congress in terms of telling us that we should have an assistant secretary at an operational level, and we're hoping that that will in fact move us forward. I will tell you, when I came into the JFK Federal Building in Boston 6 years ago, there were many federal agencies who never even heard of SAMHSA. And by the way, some of them sat inside the Department of Health and Human Services. And with Christy Hager's leadership and our working together, we were able to kind of build out a knowledge about those other federal agencies that needed to be involved in behavioral health. I want them to care as much about behavioral health as SAMHSA does. So that means, oh, by the way, I want CMS. And Representative, I would suggest you get CMS to come to one of these meetings and say, what is CMS going to pay for when it comes to prevention and promotion? And they have to begin to think more broadly and more deeply about the way in which they define prevention and promotion, and the way in which they think about behavioral health, and the way in which they can then look at some reimbursement and financing mechanisms to be able to support that. So I would suggest that all the other HHS agencies, ACL, ACF, HRSA, we're all part of that family, and we should all be talking the same language with you about what we can do and how we can support prevention. We have had, as you know, a secretary that came and went very quickly. And that secretary, we are now going to probably get a new secretary very shortly. The secretary who came in first established 3 priorities. Secretary Price said, my priorities are mental illnesses, substance use disorders, and opioids, and childhood obesity. Those areas have remained as priorities and will undoubtedly remain as priorities through 2018, even if Mr. Azar is appointed finally the HHS secretary. So our intention at SAMHSA is to continue to follow those priorities until we hear otherwise, and we obviously are following them under the direction of our new assistant secretary. We have inside SAMHSA what is known as NREP. Many of you are familiar with NREP, and if I was going to talk for a long time, I could list everything that's in NREP. But NREP is the National Registry of Effective Programs and Practices. There is a national registry that brings together all of the evidence-based practices and programs that SAMHSA has been involved in. It is a wealthy, a very rich resource of information about the programs and practices across the prevention and promotion spectrum. You will see in some of those that they were either grant programs that were started and then ended, and we learned particular things about those grant programs. There will be other practices that have caught on and have now become embedded in a lot of our work, like SBIRT. So how many people know what SBIRT is? All right, so there you have it. That's a practice that came out of a grant program that's been embedded now in a lot of different sectors and in many non-traditional sectors, I might add. And that becomes a screening tool that's hugely important. So we've got, NREP is really an important resource for all of you to take a look at, to be knowledgeable about, and that gives you an opportunity, community by community and state by state, to figure out which one of those practices has the best impact, which is the one that will have the most effectiveness relative to the needs in your community and relative to the needs of where you might apply it. And some of them are just examples here. We have, the underage drinking prevention program, Too Smart to Start, drug-free workplace programs, et cetera. Now, inside SAMHSA, we have what we call strategic initiatives. These are areas of focus that we spend time on in terms of looking at our authority, our appropriations, our regulations, our programs. And our first and foremost strategic initiative is prevention. This is prevention of mental illnesses and substance use disorders. And right now we are operating under these particular goals. We want to promote emotional health and wellness. We want to prevent or delay the onset of and complications of substance abuse to mental illness. We want to prevent and reduce underage drinking. We want to prevent and reduce attempted suicide and deaths by suicide. And we want to prevent and reduce prescription drug and illicit opioid misuse and abuse. These are our 4 target areas, which means that our programs and our appropriations are going to follow suit. And these are the things that we are going to do. What we do, we have, of course, a Center for Substance Abuse Prevention. Inside the Center for Mental Health Services, there is a prevention and promotion schedule of programs that we work on in terms of looking at those mental illnesses that we may be able to prevent. And we're also doing a lot of work relative to the emergence of these conditions. Let me first of all say that when you use the term upstream, Representative, what I think of is early and young. Early and young. That's where we should start. Really early and really young when it comes to prevention and promotion. I used to teach elementary school, and then I taught high school math. And it was amazing to me at that time that we did not have teachers learn all of the important disciplines around social and emotional learning and emotional competency in children. It's a shame. And it is the one area, as a teacher, I would tell you to really emphasize. that if we don't start at a very early age to talk about emotional mastery and to talk about social and emotional learning, we have missed generations of people. And I think that that, to me, would be one of the strongest issues that we would have, or I would have, in terms of a recommendation. I'm going to add a few words here, and there's a couple slides which I won't go over, but I cannot emphasize how important the language is that you use to talk about these conditions. For too long, we have discriminated against people who have these conditions. And we have discriminated in lots of different ways, but mostly with our language. We need to talk about people first language, and we need to talk about the fact that these are health conditions, mental, emotional, and behavioral health conditions that are like any other condition. And we have, for years, preached this. And inside SAMHSA, we don't even use the term stigma anymore. Because this term stigma creates a sense of shame, a sign of stigmata, and a horrifying sense of a high level of discrimination. So I just think it's important that we don't connote blame and victimhood. How many times in the newspaper do we read alcoholic? Do we read addict? Do we read all of these terms that are just loosely used in a way that is really highly volatile and highly emotionally cued into the way in which we offer messages about prevention. And by the way, prevention happens in communities, just like recovery happens in communities. It doesn't happen at the federal level. It doesn't happen necessarily in broad spectrums, but it happens in community. And I want to just make sure that when you look at what those practices are those practices really using terms that are helping people influence their beliefs, their behaviors, and their attitudes? And so I've provided in this PowerPoint some options where, in fact, you can use an alternative language that describes attitudes like bias and describes acts like scapegoating and those kinds of terms. And I think it's a really important issue. And I've also really talked about the fact that one of the roots of behavioral health conditions is, of course, rooted in the experiences of very young and very early experiences for individuals. That's why it's so important, Representative, that you focus on trauma and trauma as an early issue relative to the experiences of people. The majority of individuals with behavioral health conditions have experienced some form of trauma. Absolutely, positively, at least above 90% of individuals with substance use disorders and mental illnesses have experienced trauma, either early in their life or because of their particular conditions. And so looking at adverse child experiences, the ACEs information is an important idea that we are aware of what those adverse childhood experiences are, and you can see from the tree here what they are. And then there are adverse community environments beneath the tree in terms of what is contributing to the community environments that exacerbate what might be those conditions that are important to look at. So because you have brilliantly said, we're not just going to look at a narrow issue about drinking or a narrow issue about suicide or a narrow issue about opioids, we're going to look at a very broad and deep across the human behavioral spectrum in terms of prevention. That's why it's so important to take a look at how these experiences have lasting effects on behavior and health. And so the earlier and sooner that we can start to make sure that we're assessing that and we're taking a look at that, the better we are. The final thing I wanted to talk about is to tell you that there's a special issue called of academic pediatrics. It's Academic Pediatrics 2017, Volume 17, that came out in a special issue that is promoting child and family well-being and beginning to address the prevalence and also the prevention of adverse childhood experiences. And they're looking at it through a lens of health services, through research, through policy and practice. And I think that this issue is really a wonderful place for you to look at some ideas about the way in which we're trying to understand child and family health across multiple sectors. And it includes in this issue a very comprehensive national action agenda with a variety of best thinkers in terms of where you might go for some of your prevention ideas. Just a suggestion. There are some other collaborative strategic examples that I might use just to talk about what's available in SAMHSA. You go on our website, you go to NREP. There are obviously clearly prescribing education courses. Stay on Track is a school-based substantive use preventative program for students. And I think that we need to begin to take a look at expanding messaging. We've really narrowed our prevention messaging in some ways, and we need to think about expanding to sectors that include communities, parents, friends, relatives, healthcare, law enforcement, schools, libraries, grocery stores. I mean, we need to think more broadly about sending out messages about the importance of behavioral health. I will tell you that one of the most important endeavors that's going on is looking at infant and pediatric mental health. And Massachusetts is a prime example of the incredible progressive work that's going on. The Boston Public Health Commission and several other Boston-based providers have been seminal in their work in terms of looking at infant and pediatric mental health. Again, this is not overly negative. It's not trying to diagnose infants and children earlier than they should be, but that we are building a normalized way in which we are asking parents and infants and children about their emotional health. It's a very wonderful development. And finally, I would suggest that you talk to state leadership and certainly talk to the federal leadership about the way you can utilize the Substance Abuse Prevention and Treatment Block Grant and Mental Health Block Grant, your Strategic Prevention Framework money, and your state-targeted response money from the opioid epidemic that really could be used to begin to take a piece of that because you know, you can't do, you can do prevention-minded treatment and you can do treatment-minded prevention. We got to get smarter about prevention-minded treatment and thinking again more upstream out of the clinical process but into larger clinical community messages. So I would encourage you to think about using some of those funds in a different way. I want to thank you very much for the opportunity to come before you, and I appreciate again the fact that you are looking at this issue, Representative, and I stand ready to do whatever SAMHSA can do to support you and to provide for you whatever resources, whatever other materials, and whatever other grant program information we can do so. Thank you very much.
Thank you, Madam Administrator. Madam Administrator, we want to thank you, by the way, for your recommendations and your focus on early and young. We want to note that we just had, just back in October, we had Scarlett Lewis, who was the mother of Jesse, who was one of the young children who was murdered. And she came in, and interestingly, for her testimony, the grace that she had, because it wasn't a discussion of gun control, although that's very important, wasn't a discussion of other issues and violence of that manner. She was discussing why we need a focus on social and emotional learning. And focusing on the perpetrator and what could have been done differently. So I appreciate that focus, as well as I took about 5 pages of notes, so we will be following up with you. Thank you so much. Our next speaker is Michael Botticelli, who served as the director of the White House Office of National Drug Control Policy from March of 2014 until the end of President Obama's term. Michael is the executive director of the Graceland Center for Addiction Medicine at the Boston Medical Center. Michael serves as Director of Substance Abuse Services from 2003 to 2012, where he oversaw a pilot program in Quincy for police to begin carrying naloxone for treatment of the opiate overdose. Michael, parenthetically, I wanted to add, we heard you speak in D.C., Ben and myself and others. I mentioned to you Anne Marie Galvin from Situate. We heard you several years ago doing such an inspirational talk of how one person makes a difference in this field. And I do know, I want to speak for all the EDC employees, where Ben Thomas used to work for EDC, then came working for me, and hearing you speak, said that immediately after that tragedy in his family, of how he wanted to make a difference here and in helping with creating this commission. So you've inspired many people in your young years and career, and we look forward to hearing your testimony today.
Great.
Michael Botticelli.
Thank you. Thank you, Rep. Camwell, and members of the commission to do that. So just to your point, many people have inspired me, and I would not be able to be here today if it were not for the love and care of many people in this room and in this community. And it really gives me, I can't tell you, while I love my job in Washington, I still came back to all the people in Massachusetts, many of whom are in this room who I've known for a long time, who quite honestly taught me everything I've known around how to do my job. So really privileged to be here today and really appreciate the focus of this commission and the work that you're doing. So let me, I just want to, first of all, and also thank Catherine Power, who I've had the privilege of working with for a long time, and I just want to follow up on her Words Matter piece and just encourage you actually on our, if you go to bmcaddictions.org, we actually have a Words Matter pledge on our website that is free for you to download and co-brand it for your organizations. As part of Recovery Month at Boston Medical Center, our CEO, Kate Walsh, sent the pledge out to all 6,000 of our employees, asking them to sign a pledge to use clinically appropriate, non-stigmatizing language as it relates to issues of addiction. And I will say, you know, one of the final acts that we did at the Office of National Drug Control Policy was to send out a memo to every federal agency asking them to use non-stigmatizing language as it relates to substance use disorders. I don't know whatever happened to that memorandum, but at least it's in place now. So, you know, at the risk of being patronizing for many people who have, in this room, who have dedicated their life to prevention, I just want to spend a little bit of time talking about risk factors here, because I do think it really charts our way forward as we think about how do we deal and focus more on prevention. And you know, again, you know, what appears to contribute to substance use disorders is a combination of both of genetic, personal, family, and environmental conditions as it relates to this. And as I've learned from folks, you know, it appears about 50% can be attributed to genetic history and family issues, and 50% to environmental factors. And it doesn't necessarily mean that just because you don't have a family history that you can't develop a substance use disorder, and vice versa. So it's really important for us to know, one, the role that family and family history plays as it relates to issues of addiction. And, you know, this is very personal to me, and I've been very public about the fact that I'm in recovery, right? So here I am, kid, coming from a family with a history of substance use disorders. I never remember anyone, a school counselor or a pediatrician, saying, Michael, you're at risk. Because of family history. So I do think how we continue to educate our medical personnel as it relates to things like screening and brief intervention become particularly important. Catherine talked about the role that early use plays, you know, and clearly a lot of our focus on prevention-related efforts is how do we delay the first use, and I'll talk a little bit more about that. Clearly, we know that mental health issues play a significant role in terms of people's choosing to use and why people develop substance use disorders. So how we think about issues of mental illness become particularly important around those. Catherine talked about the role that early trauma plays. We know that certainly significant from adverse childhood experiences play a significant role. But one of the other pieces that I think is particularly important, and I think is particularly important in this environment, is perception of risk, right? So one of the things that we track through our federal survey is perception of risk of harm for using a particular substance. And since I'm no longer a government official, I will take this opportunity to say that while we've made great progress on many of our prevention markers, federally, one of the things that's of significant concern is perception of risk of marijuana use among youth is at its all-time lowest levels in the United States. And I think it's really important for us as we think about prevention. You know, we can't, I think, bury our head in the sands in terms of how the Commonwealth thinks about implementing legalized marijuana in the state here. You know, clearly we know parenting, and parenting plays a huge role in this, as well as adult supervision. You know, it's very clear that the presence of a loving, caring adult in someone's life can have a really positive impact, as well as social isolation. And I'll talk a little bit more about this, but I think many of you have been taken aback, as I have, about the dramatic increase. Quite honestly, it's contributed to an overall decrease in life expectancy among men, largely attributed to drug overdoses, suicide, and diseases related to alcoholism. They've been called diseases of despair. And I do think that we really have to think about the role that social isolation and social cohesion plays in the work that we're doing. And Some of you might have read the book Dreamland by Sam Quinones around the opioid epidemic. And one of the things that he says that I've stolen is the fundamental solution to our opioid epidemic is not treatment, it's community. And I believe that. I really do believe, Catherine talked about the role of community, and I feel the same way. Tip O'Neill used to talk about all politics is local, but in our world, all prevention is local. And I do think that part of what we really have to focus on is how do we create greater social cohesion in our communities to make people not feel isolated. Clearly, parent use and misuse plays a huge role in terms of whether or not someone's at risk of using. But there are other environmental factors and policy factors that really, I think, point to kind of future directions. And one is community norms. Excuse me, play a huge role, and particularly perception of community norms. So if particularly youth feel like it's normative behavior to drink or to smoke marijuana or to do drugs, that increases the likelihood of the risk that we're doing. Clearly the opposite of these are all the resilience factors, so this is what we need to focus on. Price plays a huge role in whether or not someone decides to use. And all you have to do is look at our efforts around tobacco control in Massachusetts and around the nation to understand the role that price plays. So one of our significant public health strategies as it related to reducing tobacco use was increasing the price of cigarettes. And we saw quite dramatically, and particularly the fact that kids are price sensitive, increasing the price actually decreases work. And I actually think this is an area where, unfortunately, the alcohol industry has played a huge role. Many of you, I think, remember, are old enough to remember, I'm trying to remember how many years ago, that the Governor Patrick proposed and the legislature passed legislation that removed the exemption for the sales tax for the off-site purchase of alcohol. And if I was trying to look this up, Massachusetts is one of the few states that doesn't implement sales tax on the off-site purchase of alcohol. Through the leadership of the governor and the legislature, passed legislation, created actually a dedicated funding stream from that sales tax to fund prevention efforts, and through largely efforts from the alcohol industry, put it on public referendum, and that was unfortunately defeated. But clearly price plays a key role, and is probably one of the most effective public health strategies that we have for reducing underage alcohol use. And availability plays a key role. We know, and I think all of us can probably relate to the fact that if we have bad stuff around us, that we're much more likely to do it. And we've seen in places where things like alcohol outlet density in our communities dramatically increases use. And I will have to say, as the commission thinks about, like, how do we think about communities of highest risk, lots of data and studies to show that poor communities and communities of color have higher preponderance of alcohol outlet densities in their community. So we really have to think about that. And the last is advertising. Clearly, we know there's a direct correlation between, particularly as the amount of advertising that kids see and whether or not they're going to use. So just to kind of underscore the early start pieces, I just want to talk about a couple things. So we clearly know that the early use of alcohol, tobacco, and/or marijuana is a significant predictor of substance use disorders later in life. So for kids who drink before the age of 15 are 4 times more likely to develop an alcohol use disorder later in their life. For among adults who first tried marijuana before the age of 14 or younger, 13.2% were classified with illicit drug dependence or abuse, and that's 6 times higher than those who first tried marijuana at the age of 18. And the early use of these substances is also a significant predictor of advancing to other substances like cocaine, prescription medication, and other opioids. So, with that, let me just kind of transition to what I think are kind of some areas that we'll focus on. And first and foremost, and Catherine talked about the role, we know what works here. So we have a compendium of evidence-based practices, but unfortunately they are kind of not widely implemented. And I think there are a couple things that we need to think about and who we reach out to around evidence-based practices. And one is our law enforcement and criminal justice partners and other folks in other systems. And let me just give you, I think, what is a kind of relevant example of this. Many of you may have seen that the U.S. Attorney here in Massachusetts, again, with best of intentions, decides that they are going to launch an opioid prevention campaign and use things like tombstones and very highly stigmatizing portrayals of babies with this. So part of what we, I think, have to do is create better opportunities with our prevention experts, with other stakeholders who are doing this work, because I think it's really important to do that. I've also been really concerned over the years about how we communicate what prevention is to the general public, right? So there is this still prevailing narrative that if I send someone into a school assembly and scare the hell out of kids, that's considered prevention. So I think we need to really help define for the general public what prevention is and what it isn't. Because I still think that there is not an understanding among the general public about the difference between awareness and prevention and what prevention entails. I think we need to do a better job. I will say this. I'm looking at Tracy. I think the prevention community needs to do a better job of communicating what we do. We often talk in our own language, in our own acronyms, which makes it really hard for the general public to understand what prevention is. I will also tell you, I've been, and I think it's really unfortunate, and I feel somewhat to blame for this, that in the midst of our opioid crisis, there has been little focus on prevention, and particularly the role that alcohol, marijuana, and tobacco play as it relates to our opioid epidemic. And I worry that we are not that we need to create a better connection around early use, and particularly early use of those substances as it relates to the opioid epidemic. And I've been hearing this narrative, and I have no scientific basis which to say this, but I worry, and I hear more and more, that parents are becoming much more permissive around alcohol use when they hear things like prescription drugs and heroin, and not understanding the role that early use plays in developing substance, that part of our strategy on the opioid epidemic has to be about community-based prevention efforts, which is, I think, really important. And I will say, I've been doing this work a long time, and I was saying this to Rep. Cantwell, that I think while we made significant progress during our time in Washington as it relates to this issue, I do think that prevention has gotten a short shrift in this conversation, both in terms of just the importance of it as well as funding. Catherine works for the Substance Abuse and Mental Health Services Administration, so I can say things, because I'm no longer with the administration, that she can't, right? So, one of the biggest sources that she talked about is the federal block grant, right, which Massachusetts and it's a formula grant that other states receive that has a 20% set aside for prevention-related services. I will tell you, and she probably knows the data, the block grant has been flat funded for 10 years. And when you think about the purchasing power as rates have gone up, it's diminished by about 40%. So we have to work with our Massachusetts delegation and other members of Congress. And the block grant still is the largest single source of prevention funding for states. So we have to work with our delegation to increase funding for the block grant, because particularly as it relates to prevention funding. But I think there are other opportunities here as we think about the work that we're doing. So how, in the redesign of our healthcare delivery system, of moving away from paying for services in a fee-for-service system to moving to accountable care organizations, I think present us opportunities for thinking about funding services farther upstream. So I will tell you, Boston Medical Center, we are one of the leads for the Medicaid ACO program with some of our partners in the room. And part of, when you now have to think about getting outcomes versus paying for things, it provides an opportunity to think about prevention and other social determinants of health that we know to be important. Boston Medical Center actually just used some demonstration of need money, $6 million, to fund housing development, because we know stable housing in our communities is a key predictor of people's overall health. And our focus needs to be, as healthcare delivery systems, focusing on outcomes, because that will move us farther upstream as opposed to waiting for people to hit our emergency departments and our hospital beds. So I think we have an extraordinary opportunity to do that. Clearly, community benefits can play a key role in funding. And if you're not familiar, community benefits is an IRS imposed rule that for hospitals for nonprofit hospitals that are receiving Medicare or Medicaid have to spend a certain proportion of their dollars on charity care or community benefits. And I will tell you, for many, many years, Massachusetts General Hospital has used its community benefits to fund prevention coalitions in Revere. So I think there's a great opportunity of how do we work with community benefits and our nonprofit hospitals to fund prevention-related efforts. I think it's really a great opportunity to do that. And when we were in Washington, we actually featured MGH and Revere Cares to focus on using community benefits to fund some of those work. I also think that there are continued opportunities around public-private partnerships. Many of you just have seen that the Attorney General's office just used settlement money from CVS Pharmacy in partnership with the GE Corporation to fund prevention programs in every middle school in the United States. So as we think about opportunities, we have to look at who are potential partners in the work that we're doing. From a policy perspective, I do think it's time for us to revisit the idea of price and taxes as it relates to alcohol use, because it is particularly important for us to look at this from a public health standpoint. And it's very clear that even small increases in price have a huge impact in reducing underage use and binge drinking use in the United States. It's really, I think, important for us to do that. Again, how do we work with communities to look at reducing alcohol outlet density? That's particularly important. And again, I also think, as I heard the news that the Cannabis Commission has approved things like cannabis cafes and restaurants, we also have to think about the impact that marijuana outlet density is going to have in many of our communities, and particularly advertising. And advertising is, I think, an important issue and a very relevant issue right now, as I think the MBTA looks at reversing its policy around alcohol advertising on MBTA services. I think that is really important to do that. Catherine talked about the role that SBIRT plays, screening, brief intervention, and referral to treatment. While it's not a primary prevention tool, we need to do a better job of screening people and intervening early in people's trajectory. One of the things that I think the Commission is interested in is how do we target high-need communities as it relates to community-based prevention? And one is, are there opportunities to strengthen grant language, either in federal grants or state grants, to make sure that these resources are going to communities of highest need? And some of that, I think, requires us to build the capacity of our communities to respond to grants. Often we see those people who get grants are the communities, and usually more well-resourced communities, that can hire a grant writer to focus on a grant. So, and I will tell you, I saw this, I think many of you know that the Office of National Drug Control Policy, in partnership with SAMHSA, funds drug-free community grant programs, right? So I think we're at about 700 drug-free community grant programs. And it's very clear, as I looked at who got those grants in Massachusetts, they were not necessarily going to the communities of highest need. They were going to communities that could submit a good grant application. We were actually precluded by federal legislation to put in our drug-free community grants those kinds of criteria because they're set by Congress. But I do think that we have to really look at federal funding sources and state funding sources to make sure that whether it's state or federal funding, that we are getting those resources to the communities most in need. I think we miss opportunities, and I think we tried to do a good job at the state level when we're here to really look at all the prevention funding that was coming in and ensuring that we are getting those dollars out, whether they're state dollars or federal dollars, at communities most in need. I want to talk just a couple other things, and I know we're talking primary prevention, but we need to consider and make sure that people have access to services that prevent harm from this epidemic, and chiefly making sure that people continue to have access to clean needles. I think all of you know we've seen extraordinary increases in hepatitis C among people who inject drugs as it relates to this epidemic. Clearly, access to naloxone is important, but I also want to talk, I think, about other synergies that we have here, and clearly, I think, with mental health, but with suicide prevention. I worked with folks at EDC when I was here in Massachusetts, and I served on the Action Alliance for Suicide Prevention. And how do we ensure that our federal strategies and also our state strategies understand the nexus between suicide and suicide prevention and substance use issues? While I think we made great gains, I think there's lots of opportunity for us to think, as Catherine was saying, not just in our silos, but how do we make sure that we are leveraging our prevention resources to focus on a whole host of issues. You know, one of the things that I do think if folks didn't see this, Federal Monitoring the Future data just came out yesterday, which actually has some good indicators. But one of the issues that's really alarming is vaping, that I think we really have to consider as we think about this. And you know, it's clear that youth seem to be vaping a wide variety of substances, some nice flavored kinds of things, sometimes nicotine, sometimes other drugs. And so if there are regulatory opportunities that we have as a state to think about how we monitor electronic cigarettes, but clearly what can go in them, I think is particularly important, because I think the concern among many folks in public health is that vaping can become a significant pathway, not just to smoking, but to other substance use issues. So it's, I think, something for us to pay attention to, because it seems to be one of the substance use issues among youth where we're not making great progress on. So I want to, again, thank you for the opportunity to be here today. This is an incredibly important commission, and your work is, I think, tremendously important. And if there are ways that I can continue to be engaged with this, either the commission or state level work, I'm happy to do that. Thank you very much.
Thank you very much. Now, my pleasure to introduce for our first, introducing the first panel, is Cindy Taylor, who's the Senior Vice President for the U.S. Division here at EDC. Cindy.
Thank you, Representative Cantwell, and I just want to add my thanks to Michael Botticelli and Catherine Powers for taking the time to be here today. It was very interesting to listen to you, and I appreciate you all taking the time. So, as Representative Cantwell mentioned, I am here to present our panel of EDC specialists who are going to give you all some more information and testimony. I wanted to frame that discussion just a little bit about who EDC is and what we do. EDC has been around for just about 60 years, and we've been a leader in behavioral health prevention and promotion efforts across the country. In fact, our stock in trade, so to speak, has been to translate prevention research into effective, useful, and evidence-based practice. But we're not an ivory tower. Our professionals are on the ground, working closely and directly with communities. We're known for our strong collaboration with educators, medical professionals, social service providers, and public health workers to really construct effective responses to suicide, substance misuse, and other forms of preventable injury and death. We've learned a lot about what works and what doesn't work. And we're grateful for this opportunity today to share some of that with you. So for the next 45 minutes, you're going to hear from Jim Vetter, who is a member of the commission, Kim Dash and Sherry Kessel-Schneider, who are senior researchers here at EDC, and then also from Lauren Gilman, who heads our MassTap program, and she's going to describe that program to you. So I am proud to present this panel. They're going to provide you with some very interesting and useful information about what we've learned. And thank you. I'm going to turn it over to Jim.
Thanks, Cindy. We really appreciate the opportunity here at EDC to share with you some thoughts about what does work in behavioral health promotion and prevention, and a little bit about the question of, we know it works, why aren't we doing it? That we at EDC take a socio-ecological approach to promotion and prevention, really looking across the span from programming that focuses around the individual, work like our infant and early childhood mental health consultation work. We look at relationships, like audio programs that work with parents on how to talk with their young people, their adolescents, about difficult topics like sexuality and substance use. That Lauren will talk about work we're doing with communities, supporting communities' work around substance misuse prevention. And we also work on the societal level on things like our technical assistance for the Essentials for Childhood framework out of the Centers for Disease Control and Prevention that looks at the social, how to change within states, including Massachusetts, the social determinants of health that can lead to safe, stable, and nurturing relationships and environments for children. So on this commission, we're charged with behavioral health promotion. So what does that mean? On the commission, we've settled on the definition of strategies designed to create environments and conditions that support behavioral health and the ability of individuals to withstand challenges. And that relates to some other long-standing definitions in the field, like from the Institute of Medicine's groundbreaking 1994 report, where they talked about mental health promotion for young people as being interventions that aim to enhance the ability to achieve developmentally appropriate tasks and a positive sense of self-esteem, mastery, well-being, and social inclusion, and strengthen the ability to cope with adversity. So rather than just focusing on preventing problems from occurring, behavioral health promotion is about fostering wellness, helping young people and adults across the Commonwealth to live the best possible lives. So how do we do that? We'd like to offer in our testimony 4 main ideas. And I think you'll find that these will relate to some of the comments we've been hearing already. The idea of starting early, using science, use local data, and work with each other to accomplish these important goals. I'm going to be sharing with you about the first idea, starting early. So why should we start early? Why should we focus on behavioral health promotion? That in the work that I do here at EDC, as well as in the work that I do with the Social Emotional Learning Alliance for Massachusetts, we know that there are many communities across the Commonwealth that are focusing here. We also know, as Administrator Power talked about and others, that it's really important that we make sure that we have appropriate supports across the full range of behavioral health positions in society, that we need to think about how to promote behavioral health. Clearly, we need prevention. There has to be treatment for people who are having mental and behavioral health issues, and we need to have systems in place that help people maintain their wellness once they're in recovery. And if we look around the commission, if we look around this room, we have people here who really represent all ends of this continuum. And we know that that's vital. But under the visionary leadership of Representative Cantwell, in this commission, we're really focused on these early stages of the continuum about what can we do to make sure that fewer people need higher level service. And the name of the commission is a special commission on behavioral health promotion and upstream prevention. So when we talk about upstream in the field, what are we talking about? Well, this really goes back to a classic public health story where a woman is walking through her community, takes a shortcut, and sees there's a stream and there's a thrashing sound. A young person is there in the water. So the woman does what any of us would do. She gets in the water, she pulls that young person out, gets them to shore. But then she sees another young person is there in the water. She jumps back in, and she sees another further upstream. She calls out, gets friends and neighbors to join her in this effort to pull these young people out of the water. But as the day goes on, as they start to get a kind of community system in place to pull more and more people out of the water, she walks away. And over time, that flow of people thrashing in the water dies down a bit. She walks back, and one of the people still involved in the rescue effort says, "Where did you go?" She says, "Well, I walked upstream to see why people were falling in and what we can do about it." Our work on the commission is to walk upstream, to look at why people are falling in and what we can do to prevent that from happening in the first place. And we know from the science that if we do this, if we focus more of our energy around behavioral health promotion and wellness and prevention of behavioral health disorders, we can shift so that fewer and fewer resources are needed for the higher levels of intervention that will always still be there. So what does this actually look like, behavioral health promotion? Well, we know what works. There are now decades of science about how you promote behavioral health in young people. The Collaborative for Academic and Social Emotional Learning have been leaders in compiling that research, pulling together what really does work. And they've come up with really 5 categories of the social emotional learning approach that are areas that we really can make a difference, that by providing appropriate interventions, we can really help young people and the adults they become to increase self-awareness, to be able to recognize their own emotions, their own strengths and needs. We can help young people and the adults they become to increase their competency with self-management. How do you manage those difficult emotions? How do you set and achieve goals? Then externally, we know that we can help young people to increase social awareness, to understand the feelings, perspectives of others, including people who are different than themselves, and develop those relationship skills, communication skills, negotiation skills, and all of that pulls together for responsible decision-making. And that might be decisions about activities, about schoolwork, and about substance use. So if we do this, if we do, as Administrator Power talked about, if we use this kind of social emotional learning approach as one of the behavioral health promotion approaches, what results do we get? What does the science tell us? Well, we know that there are interventions that we can use. And CASEL, like with NREP, has reviewed a series of programs and looked at, are these programs evidence-based? Do we have reason to believe that these programs will actually work? And they also looked at, do these programs provide the kind of support that communities need to actually implement them? So not simply something that was done in an academic institute someplace. These can actually be used. And on the CASEL website, there's a guide that our communities can use to find these kind of programs. If we implement them, what can we expect? Well, the research shows. There's a recent meta-analysis that looked at over 100 high-quality academic studies of these social emotional learning programs, and they found that if these programs are implemented in our communities, we see reduced emotional distress, less depression, less anxiety. We see fewer negative behaviors, less acting out, less conflict. We see improved attitudes and behaviors, a better focus around community contribution, schoolwork, and it even resulted in better academic performance. Meta-analysis showed that there was, on average, an increase of 11 percentile points on standardized test scores. So, we can see that if we take this approach, if we start early, starting early can save money and save lives. We would recommend that the Commission continue to focus on these early stages of behavioral health promotion in order to have the best return on investment and the best quality of life in Massachusetts. So that's about starting early. Now, my colleague Kim Dash will tell us more about why we should use science.
Great, thank you so much, Jim. Hi, everyone. I'm Kim Dash. I'm the scientific advisor for SAMHSA Center for the Application of Prevention Technologies, also known as the CAPT. As Dave pointed out earlier, it's housed at EDC. As the scientific advisor, I oversee the development of products, learning resources, tools, and services developed and delivered to SAMHSA grantees to help them facilitate the implementation of evidence-based programs and practices. And so what I've learned in my job is that there's lots of information out there on programs that work to promote behavioral health. And as many have mentioned, including Administrator Power, Jim, and Michael Botticelli, many of these programs can be found on national registries or inventories dedicated to reviewing research and featuring programs with strong evidence of effectiveness, as well as promising programs and even programs with insufficient evidence of effectiveness. And on the SAMHSA National Registry alone, there are over 200 unique mental health promotion programs and over 130 substance use disorder prevention programs mentioned. And on these sites and others, information is provided on specific programs and policies, their core elements, how they were evaluated, the quality of those evaluations, the extent to which materials are available to communities to help them implement these programs. And part of our job at EDC has been working closely with schools, communities, and states to help them navigate some of these registries, because it's not always, the information there is not always so straightforward, and sometimes the way in which research findings are presented is not always necessarily transparent to communities. It's kind of figuring out what to do with that information has been a challenge. And while there seems to be a great deal of evidence on which programs, policies, and practices produce the kinds of results that we care about, we know less about the cost effectiveness of specific programs. But still, there is some evidence to suggest that specific upstream solutions have the potential to produce substantial cost savings. And these are listed here and tend to fall into the kinds of promote prevention categories that Jim featured on the continuum. These kinds of strategies promote cost savings through cost per healthy life year gained, savings from better health outcomes, and reduced expenditures in the criminal justice system. So we know which behavioral health programs work, right? We've heard that. I think I may be the third or fourth person to say it. And we know that they have potential cost savings. So why aren't we implementing these programs and practices at scale? Why not just, mail out a box with the program and some instructions? Well, change is hard, and there are many factors that influence whether we adopt and implement new programs. These factors typically have something to do with the way the program is designed, certain organizational factors, and of course, contextual factors. So at the program level, we want to know, for example, are there any training requirements? How complicated is this program? How many moving parts? How many ways for things to break? Excuse me. Can I adapt the program to fit my needs and still get the same results? Was the program evaluated with populations similar to the ones I serve? And to what extent were practitioners and potential participants involved in actually developing the program? And at the organizational or school level, we want to know, was the program designed to be implemented by an organization like mine? Is there dedicated funding to support this program implementation? Is leadership willing to provide support? And are there incentives for staff to participate? And I have lots of staff turnover. How is this going to affect my ability to implement one of these programs? And then we have to consider all those contextual factors. Is reimbursement available for specific kinds of programs? Is the program in keeping with community standards? Is there cultural or political resistance to any specific kinds of interventions? So consider, that gun laws have the potential to effectively save lives and reduce costs associated with gun deaths, including suicide. But no matter where we stand on gun control, we have to admit that the ability to implement such measures is difficult in the current political climate. And then, are there other community-level priorities that override focus on mental health promotion? Are we a little distracted by what's happening downstream and not thinking about what we can do upstream? So given the challenges to implementing evidence-based programs, there's been lots of thought given to coming up with processes that facilitate their implementation. I've provided a few examples on this slide, most of which go by very technical, unappealing names, but many communities and schools have found these frameworks helpful in moving research to action. These approaches have a few things in common. They are all data-driven. That is, data is collected or used to inform selection of evidence-based programs. This may be surveillance data or epidemiological data on specific risk and protective factors, or assessment data on perceived needs. The focus, they also focus on selecting evidence-based programs that meet the needs of populations to be served, as well as fit with the capacity of the adopting organization to implement them. These processes tend to be collaborative. They acknowledge the importance of involving different stakeholder groups and involving them in the selection and implementation of specific evidence-based programs. And again, both Lauren and Sherry are going to be talking a little bit more about some of these specific steps, Sherry about data, and Lauren about collaboration. The other thing I think that's worth pointing out is that many of these processes acknowledge the importance of ongoing training and technical assistance, or involving intermediaries to facilitate implementation and help organizations address specific contextual challenges. So, for example, EDC serves as an intermediary. We work with SAMHSA, and we use the Strategic Prevention Framework when working with SAMHSA-funded grantees to develop prevention plans. So, beyond such processes, we can incentivize the implementation of evidence-based practices through law. And so how do we prioritize evidence-based practice to promote behavioral health? Well, I think other states may provide us with some examples of how this can be done through legislation. I'm going to focus on, excuse me, Washington State, which has which was recently featured in a Pew Foundation report on how states have passed laws to facilitate adoption and implementation of evidence-based programs. Coughing. Washington required agencies that deliver prevention and intervention services for children's mental health, child welfare, and juvenile justice to substantially increase their use of evidence-based programs using research and inventory methods developed by the Washington State Institute for Public Policy and the University of Washington. And this is the kind of thing I think that Ben was talking about earlier with results first. Washington also required agencies to establish monitoring and quality control procedures to ensure that programs were effectively implemented. And Washington enables providers to submit evaluations of homegrown programs to a panel of experts. Programs with strong evaluations are added to the inventory. Washington also, as I mentioned, had the benefit of key intermediaries like the University of Washington to aid in implementation. And this intermediary was especially important in helping providers overcome challenges in building and retaining staff expertise, creating data systems that support fidelity monitoring, and evaluating programs in areas where few evidence-based program models exist. And that last one is especially important as we face certain health crises for which there are few evidence-based programs. I think Washington shows us the way in terms of how we might go about this here in Massachusetts. And now I'm going to turn things over to Sherry Ketzel-Schneider, who's going to talk a little bit more about how we can use data to inform program planning.
So thank you. I'm here today to talk about the importance of collecting data that monitors health and risk behaviors of populations, particularly the value of local data. I've studied, sorry?
Yeah, can't hear.
Okay, sure. I've studied, is that better? Okay. I've studied adolescent health for my entire career, and since 2006 have directed the Metro West Adolescent Health Survey, which is a large-scale survey initiative here in Massachusetts. It's shown me over and over again about that there's no substitute for collecting, analyzing, and understanding local data. There are many excellent state and national surveys, such as the Youth Risk Behavior Survey, Youth Health Survey, that are done right here in Massachusetts. And such surveys have very important, they serve very important goals. They help to determine the overall prevalence of health and risk behaviors, determine whether those behaviors are increasing or decreasing or staying the same over time, to help see what behaviors are co-occurring, like we've heard a lot about today, and to look at what populations are being affected most, and in addition to monitor progress towards achieving state and national goals. But state and national surveys don't always drive local change. And why is that? There are many things that I've commonly heard in communities, and you've probably heard them too. Things like, that doesn't happen in our community, or it's only affecting a small number of people here, or maybe other communities are worse off than we are, and why should it matter to us? Why should we care? And those are some reasons why state and national data don't always stimulate local change. So why is local data important? It reflects your community. That's the first thing. It's really hard to hold on to some of these thoughts and perceptions when you have data that reflects the people around you. You can't ignore it and say it's happening somewhere else with somebody else. When local data is collected, you can survey a large part of your population so that you can feel confident that the data you're collecting is really representative of those around you. You can adapt your data collection instruments to reflect new concerns and emerging needs of your particular community, whether it's to explore the extent of opioid use, or bullying victimization in schools, or to understand the extent of marijuana use amidst the changes that are occurring in our state now. You can use local data to make comparisons between your community and state and national data and other community data if that's available to you. And local data cannot be ignored by stakeholders, whether it's parents, families, community agencies, school administrators, business owners, or even youth. So local data empowers communities and stimulates change, bringing people from a place of lack of awareness or denial to feeling like they really do understand what's going on in their communities and they're prepared to act. It really gives them a better understanding of the scope of a problem, an examination of populations at elevated risk, maybe such as looking at the LGBTQ community and them being at a higher risk of bullying victimization, or girls reporting a greater amount of mental health problems. Once a community can look at its data, the patterns that exist, it can see the relative scope of various issues, what should be the priorities, and they can make data-informed decisions about that. Having local data brings together stakeholders, as I've said, so that they can come up with creative, effective, and also science-based, evidence-based solutions to address the concerns. And as steps are taken to move forward, they can also help to determine whether their efforts are making a difference. So local data really works best when it's collected repeatedly over time. Once a community has some baseline data, it can begin the process of identifying and implementing changes in local policies and programs and practices. A second round of data can then help to monitor their progress and set new priorities, and that will lead to further change at the local level. And so on, creating a positive feedback loop that institutionalizes the idea that local data really drives and measures change. So I'm thrilled now to be able to highlight an exemplary example of an initiative funded by the Metro West Health Foundation in Framingham. Our project officer, Rebecca Donham, is here today. And this is an initiative that began in 2006 when the Metro West Health Foundation realized that communities were lacking local data. This was an issue for the foundation as a funder of local programming, but even more so for the 25 communities that it served, who were determining priorities and planning, often with limited local data to support their efforts. So the Metro West Adolescent Health Survey, it's a regional initiative, but the focus of it has been all along local change. And over the last 12 years, it's increased the capacity of local communities to make data-driven decisions. Just a little background about the project. As I said before, it serves 25 communities. It's a survey that's been done every other year since 2006. The original commitment was to do a survey for 10 years, and now we've extended on from that. The foundation has continued to fund it, and we are preparing for our 2018 survey now. It's based on the Youth Risk Behavior Survey, if many of you are probably familiar with that, that looks at behaviors such as violence, substance use, mental health, sexual behavior, nutrition, and physical activity. But being a local survey that is designed to address local needs, we've also been able to add questions to the survey to learn more about things that are of concern in the communities, like stress and anxiety, help seeking, opioids, social media use, and protective factors like adult support and school attachment. Community participation has grown such that over the last 3 survey administrations, we've had 100% participation from all of the districts in the region and 90% of students in the region participating in the survey. That amounts to over 40,000 surveys collected at each administration. And with the overall goal to drive local change, we not only are able to conduct the survey and provide customized reports to all of the communities, but also to provide technical assistance to support effective and strategic use of the data. I'm going to give you a couple of examples today of when we have seen that. I could give you countless examples of how the data has been used over the last more than a decade, but I'm going to highlight 2 today. The first is on preventing bullying. The Metro West Adolescent Health Survey was one of the first large-scale longitudinal surveys to be collecting data on cyberbullying. And that has allowed us to look at trends over a long period of time, more than a decade, and understand how prevalent it is related to school bullying. Here you can see middle school data from 2006 to 2016, and the blue line here indicates what we've observed for school bullying, which is that there's been a substantial decrease starting in 2008 and coinciding with increased attention towards the issue of bullying, as well as the legislation, the statewide anti-bullying policies that were implemented shortly after that. However, despite these efforts, what we've also seen is that there's been a slow and steady increase in reports of cyberbullying victimization over time. Many of our communities really had no idea of the scope of the problem of bullying. They were often just seeing, they knew a lot of it was going on perhaps, but they didn't really know quite how much, and they were just looking at reports and police reports, school reports, and things like that. But the survey gave them a better sense of the true scope of the problem, and especially with cyberbullying, which is much harder to observe and to see. So this data really gave them a good handle on that. Now, if you look at the next slide, this takes that same data you just saw and breaks it down by gender. And what you're seeing here is that not only is the prevalence of bullying, and especially cyberbullying, higher among females than males, but that it's also risen more dramatically among females than males, such that now in our most recent 2016 survey, what we've seen is that more girls are reporting cyberbullying victimization than school bullying victimization. You can see by the crossing of the lines at the end there. Excuse me. So because we saw that across many communities, and because the data was local, communities were able to act on it. So the bullying situation was noticed by Medway, who felt like they really needed to increase their reporting, both to get a better handle on the situation, to understand more the specific types of bullying that were occurring, and to be able to respond and increase prevention efforts and awareness. In the town of Needham, for the first time, they were looking at the data around their middle school youth in particular and the increase among girls victimization that they saw. And so they wanted to take that to the students and really help the students work with them to understand what to do about the problem. And in addition to social emotional learning curriculum that they have been implementing in advisory panels, like you heard Jim talk about earlier today, they've also taken some steps to have some gender-specific meetings for girls and for boys. And in the meetings for girls, they're able to address things like how girls use social media, how they identify themselves online, and what relationships are like online, and how it is affecting bullying behaviors as well. The second example today has to do with stress and anxiety. And you've all probably heard in the last few weeks and months that there's been a lot of attention around an increase in anxiety among adolescents. And so we noticed a couple of years ago already with our 2014 data, we already noticed that that was beginning. And here what you can see is reports of stress among middle school youth, which is the dotted line on the bottom, and high school youth, which is the solid line on top, and you can see that dramatic increase in reports of stress over the last couple of surveys. So our districts who had local data were able to see this data and act on it before it became a headline in the news. And I would say that the many improvements that we've seen in education, mental health programs, and community collaborations to address mental health are among some of the most important changes that we've seen as a result of this data. And I'm just going to share one example of that from Medfield, when they were able to share the data with their school committee and their school administrators. They were able to convince them of the fact that mental health was really affecting student safety and student learning. And with that new awareness and support, they were able to get support for increasing school staffing related to mental health, so school adjustment counselor, guidance counselors, and social emotional learning director to address this issue as well. They were able to get support for implementing the Signs of Suicide program in 3 grade levels, and they also, by sharing this data with teachers and other school staff, they were able to increase the empathy that teachers were feeling for students who were experiencing mental health problems. These are just a couple of many examples about how local prevention efforts have been driven by data. It's now been institutionalized and is looked to as an essential basis for prioritizing adolescent health issues at the local level and determining how to respond. EDC has been fortunate to play an important part of making that increasing that data-driven change. And I would also say that collaborations are a really important part of making that happen. Our next presenter is Lauren Gilman, and she's going to be sharing about how local partners can work with each other to get results in their communities.
Thank you, Sherry. Can everybody hear me okay? Oh, let me just put this here. So, my name's Lauren Gilman. I'm the project director for MassTAP, which stands for the Massachusetts Technical Assistance Partnership for Prevention. We're funded by the Mass Department of Public Health, by the Bureau of Substance Addiction Services, also known as BSAS, to provide support, guidance, and resources to communities throughout the state engaged in substance use prevention work. And now, we all know when we hear the term substance use these days, a lot of people think about the opioid crisis. And we all know that we're in the middle of a crisis. And of course, as others have said before me, we all must do what we can to save the lives of people who have substance use disorders, to prevent overdose deaths, and to enable those who are ready to move into treatment and recovery. But really, we can't Narcan our way out of this crisis. Just like the story that Jim told about the children floating down the river, if we don't work together now to promote behavioral health and prevent substance use, we won't ever stop the flow of people who become addicted and need to be saved from overdose. And fortunately, many of us, including our funders at the state level, already understand this. And the programs funded by the Bureau of Substance Addiction Services for primary prevention of substance use are required to have a community-based coalition at the center of their work. Part of MassTAP's job is to work with program coordinators to ensure that these coalitions include a broad range of stakeholders, from local health departments to police, schools, mental health providers, treatment, recovery providers, that's just to name a few, and that these groups have a structure and a process to plan and to make things happen together. So does this look familiar to anyone? When Kim, when Kim was talking just a little while ago about prevention science, she told us that this, which is called the Strategic Prevention Framework, is one model that communities use for planning and implementing effective strategies. So this is the model that has been developed and promoted by SAMHSA at the federal level, and it's being used as a framework for on-the-ground prevention that's being done by communities that are funded by BSAS. And our role as technical assistance providers is to guide the communities through this process, which starts with assessment. So as Sherry described in her part of the presentation, the first step is always to start with the data. And just like a doctor wouldn't or shouldn't jump to a diagnosis without first examining the patient, the assessment stage is all about diagnosing what's going on in the community. So we have to think about the community as the patient. So the better the local data, the more accurate the diagnosis. If there's good longitudinal data, we can look at how rates of substance use among youth have changed over the years. For example, is there less drinking? Is there more marijuana use? Is there an uptick in the use of other substances? And then what about other related issues like depression, anxiety, stress? And then our team, the TA team, also encourages the community-based coalitions to look at what's called archival data, if it's available. So if it's possible, it's great to look at police data about drug arrests, or have there been busting a lot of parties with underage drinking? And also, if it's possible, to look at school data. Have there been a lot of suspensions, and what for? What's going on? And then finally, it's really important to talk about the why, and this is what we'll call qualitative data, to ask youth and parents and teachers about what they perceive is going on in their communities. And MassTap has been able to provide some tools to coalitions, for example, to help them run focus groups and really to ensure that they're hearing from all sectors of the community when they're doing this. So the next step in the strategic planning process is capacity. So after compiling and analyzing all the data, the next step is to look at your community's capacity. What strengths are already there? For example, is there a supportive business community? Do you have educated parents? Is there a strong faith-based community? And then what are the gaps? And perhaps most importantly, who still needs to be at the table? So to get a full picture of what's happening and to be able to address it, all of these sectors need to contribute their own individual points of view. So I'm sure people have heard the expression, nothing about us without us. And this slogan came into use in the arena of disability activism, but really it applies to all kinds of community work. We can't expect to reach young people without including them in the conversation, to find out what they're experiencing, what messages resonate with them, and where they get their information. And the same is true for parents, for teachers, police officers, community leaders. Sometimes our job as TA providers is to remind the people who are immersed in the work about what voices might still be missing, and to help them think through a process for bringing in these different community sectors. Is there, for example, is there a group of immigrants that's not represented in the coalition? Or if the focus is on underage drinking prevention, are liquor store owners brought into the conversation as partners rather than being perceived as the enemy? Sometimes this inclusive process can be overlooked in a time of crisis, like right now, but part of our job is to keep reminding the coalition leaders of how important this is. So the third step of the strategic prevention framework is strategic planning. And the idea here is to think through what will have the most impact before jumping into some sort of strategy or activity that maybe happened in the past, or maybe some other community is doing it, but it's in a completely different context. So we work with the local coalitions to go back to their data and to determine which intervening variables seem to be directly correlated with positive or negative outcomes. So, for example, if you're talking about underage drinking, is easy access to alcohol a big problem in your local community? Or is it that community norms are favorable to underage drinking, like somebody said before? Is it a culture that thinks of this as a rite of passage for young people? Or if you're working on the issue of prescription drug misuse, is the issue that young people have a low perception of the harm associated with taking medication not prescribed to them? Or is it more that there's just a lack of awareness of proper medication disposal? So after identifying a list like this of potentially important variables, the coalitions work together as a group to prioritize. Which ones make the most sense to focus on right now? What can make the biggest impact? What can we do that builds on our strengths as a community in a way that will have the support of the people we need to make it happen? So now I'd like to share an example of how a coalition made really good use of data and then were able to do something proactive because of having all the right players at the table together. A colleague of mine shared a story about a group of communities that she works with in the Metro West area, which happened to have great data because through the Metro West Adolescent Health Survey. And so it was actually Sherry who helped them to look more closely at their data. So they were looking at students who had reported using alcohol in the past 30 days, and then they also were looking at answers to a question about the presence of a caring adult in school or in their community. So as you've also heard from some of the previous speakers, research has shown that this is often a protective factor, that kids who can identify such a person are less likely to use alcohol or other drugs, to be involved in violence, to drop out of school, even to contemplate suicide. So this group, this coalition, discovered that students who did not or were not able to identify a caring adult in their community outside of school were more likely to report drinking alcohol in the past 30 days. So this was a really important finding, but then the question was, what do we do about it? So this is where having a broad representation of community stakeholders around the table made a really big difference. In addition to prevention folks and police and school representatives, the director of a local Boys and Girls Club had been coming to meetings and, kind of wondering, what exactly am I doing here? But at this point, when he heard about this intervening variable about adults, being there for kids in the community, he jumped on it. And he helped the group to develop a strategy to train youth workers so they'd have a consistent understanding and approach to building relationships with young people. And this coalition chose an approach that's supported by research about connection and inclusion being linked to positive outcomes for young people. So as for the impact of this strategy, which is now being implemented in 6 different communities in the Metro West area, we're hoping that there'll be some indication of progress in the next few sets of data from the Metro West survey. So the next step in the process is implementation. After all this planning, it's finally time to make things happen. And I've heard it said that we have to go slow to go fast. I'm looking at Tracy over there right now. Basically, the only way to be successful is to take the time to analyze the data and build the relationships it takes to work together effectively. Sometimes our role as TA providers, technical assistance providers, is to help coalition leaders to communicate this message when they feel pressured by community to just do something. In the middle of an epidemic, there are people dying. It's hard to just slow down and follow a process. But in the long run, it's the only way to ensure good results. So sometimes the communities we work with, we help them get the language together to explain this to people in the community. So the final step of the strategic prevention framework is evaluation. But really, it can't just be the last step in a process. It needs to be considered and integrated throughout. Coalitions need to examine how their implementation is going, whether it's reaching the right audience, and how it's being received. And if a community has quality local data, they'll be able to determine if change is taking place over time. So I just want, for right now, I'd like to thank this commission, the Promote Prevent Commission, for giving us the opportunity to talk about what we at EDC believe are the core components of behavioral health promotion and upstream prevention. The communities we serve here in Massachusetts and across the country follow a similar model of starting early, using local data, applying research-based lessons to practice, and working together. And I think we all recognize the value and power of communities coming together with the recognition that no issue exists in a vacuum and that they're all interconnected. I think we also all understand that collaborative approaches are needed to address complex problems and that going upstream is necessary. Our hope is that the state will continue to support local communities in using a collaborative, data-driven process, such as the one that substance use prevention coalitions are using right now throughout the state. And it's really amazing, I think, that this commission is bringing together stakeholders and decision makers from various state agencies, various sectors, public, private. What all of you are doing is sort of a parallel process to what's going on at the community level. And when coalitions work together for positive change, it demonstrates an understanding that behavioral health can't be siloed and that cross-sector collaboration needs to happen at all levels, from local to state to federal. So in conclusion, Good collaboration is primary prevention. It's the only way to really get at the root causes of issues and to address them in a practical, sustainable way. Thanks, everyone, and we're happy to take questions from the commission.
Any questions from any of the commissioners? Seeing none at the moment, we are going to do a 5-minute bathroom break. Everyone has a list of the people who are going to be testifying next. So folks, I don't know if it's been passed out to folks, but I think we have 15 folks who are going to testify. So everyone who is here who knows testifying, we're going to do this break, but then it's Stephanie Sunderland Ramsey. You're up first for Prevention Program Coordinator. Dr. Joel R., it looks like Medical Director, Mass Association of Health Plans. Dan French, Executive Director for Center for Collaboration Education. And Joe Schran, Dr. Joe Schran from the Chief of Adolescent Psychiatry at High Point Treatment Centers. They're going to be the first 4. I want to give people time, though, if you had any questions for any of our experts who are here. Seeing no questions at the moment, what I do want to ask is if we can have each of the PowerPoint presentations, if you could be able, through Jim, maybe if we could have them all to make sure we put those online and that we can give them to all our commissioners. But from here, it's going to be a 5-minute break. Those other folks I just called out are going to be ready to testify. And just so I'll reaffirm when we come back, everyone testifying, we look forward to hearing from everyone. It's going to be 3 minutes per person, though, just so that we can hear from each and every person and be able to get your information across. So thank you so very much. Appreciate the expert testimony. Thank you.